Please join me in welcoming to the Distinctive Voices podium, Dr. Douglas Drossman.
Thank you, Joanna. It's really a great pleasure to be here. I'm honored to have been asked, and I hope what I have to tell you will be of interest and maybe helpful. How many of you here are physicians? How many of you here have ever been patients? So we have something in common in terms of what we're going to talk about. I would like to talk about something that's very important to me, something I've made a commitment to at this point of my career, and that is helping improve communication skills and the physician-patient or the patient-provider relationship. And I think we're in a bit of a crisis with that. And what I want to do is show you where the problems are and maybe how we can help to improve it in the future. This was a note that a GI fellow left on my desk after seeing a patient of mine. And I think it displays, in many ways, his frustration. Now, admittedly, the patients that I see are complex. I deal in the area of functional GI and motility, irritable bowel, chronic pain. So this is a group of patients that are very difficult to many times understand and to manage. And like patients with other functional somatic syndromes, chronic fatigue, fibromyalgia, these conditions don't fit the modern healthcare system. And there are reasons for that. Our educational system is not designed to effectively teach us about these patients. I'm going to show you why. About 4 years ago, I made a presentation at the International Foundation for Functional GI Disorders, and I said that the concept of separation in mind and body is so dominant and pervasive in our healthcare system that it has profound negative effects on research, patient care, and the patient-physician relationship. Now, it wasn't always that way, and I'm going to go into detail about how we got there. Back over 2,000 years ago, Plato and then later Aristotle and Hippocrates talked about the concept of holism, that the mind and body are joined. The physician takes care of not the disease part, but the whole person. But things changed rather dramatically in the 17th century. Now you might ask why that changed. And one reason that it might have changed is if you've read Gladwell's book, he talks about for major changes in society to occur, society has to be primed and ready for that change. Now, one example is Steve Jobs and Bill Gates. They would not have had the tremendous success that they had in the computer industry if it were not for the fact that they were doing their work at the time that mainframe computers were going into the home. If they did it 10 years earlier or 10 years later, it might have been a different experience. Well, what happened in the 17th century? At that time, there was pressures towards separation of church and state. Now, at that time, René Descartes came up with a letter he called Meditations on First Philosophy, where he said, and this was different from the past, that there's a separation from the machine-like body, or res extensa, from the thinking mind, or res cogitans. Now, what does that have to do with medicine? Well, at the time, the human body could not be dissected because the spirit was thought to be there. Now, with the separation of mind and body taking hold, the spirit and the mind was lifted from the body, and now the body could be dissected. And with dissection came later the science of pathology. Now you could actually see disease. And the science of medicine and pathology developed. And then later you had histopathology, looking under the microscope, radiologic imaging, nuclear imaging, and all of this is based on morphology. If you see an abnormality, you can define it and specify it as a disease. But there's a problem with that. What if you don't see anything? Now, as it turned out at that time, when people experienced abnormalities of behavior or mental illness, you couldn't see anything. They were considered insane or even possessed. and they were relegated to the asylums not to be studied. And in fact, it wasn't until the beginning of the 20th century that Benjamin Rush brought into the medical schools the concept of studying mental health and mental illness. So there has been this separation going on where people who complain of symptoms where you don't see anything may have a different value. And that's illustrated here. What we know now in our biomedical understanding is that disease we implicitly understand as verifiable. You can see and measure it. It's now called organic. It means it's real. And then at the bottom of the hierarchy is illness. And if we define disease as measurable abnormalities, we define illness as the patient's perception of ill health. We hope it correlates with disease, but it may not. And that's now considered functional. So these patients we were referring to before with symptoms without anything being seen on X-ray are considered to be functional: fibromyalgia, chronic fatigue, and the like. Now, if we carry this to the research model, what evolved was considered Cartesian reductionism. And the concept of Cartesian reductionism is that there is a biological predisposition. Let's say I'm a gastroenterologist, so the NOD2 gene for immune surveillance, which under the proper environmental exposure, a disease gets expressed, a phenotypic disease, let's say Crohn's disease, and then that's supposed to correlate with the degree of illness that the patient experiences and the clinical outcome. Now, there could be psychologic overlay, you get depressed from your condition, and so on. But this model looks good, but there's a fallacy for those of us who work in clinical medicine. In terms of unilateral causality, a single altered biologic entity leading to a single outcome, what about diabetes, HIV, cancer? These are multi-determined, multi-genomic, heterogeneous entities that have different predispositions. And what about the correlation of disease with illness? All doctors and perhaps patients want to see the disease explain the illness that you experience, but you know that you may experience something and your doctor won't diagnose anything. Take, for example, someone who has a peptic ulcer, and that individual has no symptoms whatsoever and goes to the emergency room because the disease got so bad it perforated or obstructed. And compare that to a person who goes to the doctor repeatedly with typical ulcer-like pains, and they do endoscopy, and they see very little in the way of inflammation or nothing at all. So how do you explain illness without disease? That's where we have a problem in this dualistic system. Now, here's an interesting study that shows the dilemma. Kurt Kroenke, who's well known in this area, did a study in the ambulatory clinic of the top 10 conditions shown on the bottom, seen over a year in the clinic. And you see the numbers up there. And what's shown is in blue is the proportion of patients where an actual structural disease was identified. And what are we seeing? Maybe 10%. So although we're trained to diagnose and treat disease, the reality is we're treating illness. And if we adhere to the idea of finding disease, we could go on forever, and that's shown in cartoons. One of the ways that cartoons could have value is they can help us laugh at it, but it also brings us to the reality. How about this one? Several years ago, I was a visiting professor at New York University, and I gave grand rounds, and then I gave a residence report where they presented a very difficult woman middle-aged woman who had severe abdominal pain. The workup was negative, no diagnosis was found. And I know that they were expecting me to pull some disease out of the hat, but that wasn't the case. It was chronic functional abdominal pain, which is very common. And we got into a discussion of their attitudes and feelings around it. And they really all expressed their frustration, not having a diagnosis, not knowing what to do. The resident who had the patient even talked about his anger at the patient repeatedly coming back, asking for help, and he couldn't do anything. So I said, what if on the next visit you were able to make a diagnosis of pancreatic cancer? The room got quiet. The resident heaved a sigh of relief and he said, well, at least we have something to work with. The patient would die, but this shows you the power of feeling you have some cognitive understanding of what's going on, when in fact, these functional somatic conditions are real and need to be understood in a different way. If you go into subspecialties, you can hide behind your specialty. Here, the gastroenterologist is actually doing his job by showing a negative endoscopy, because his job is to scope, and the patient is still left with all sorts of questions as the doctor reassures the patient to say everything's okay. And you can go on and do a lot of studies. So this says, they removed everything they could, now they say it's all in my head. So this is a real problem, because our society, what does it reward doctors for? It rewards them for doing procedures. We get reimbursed by third-party payers for doing procedures, whereas the time spent with the patient is not reimbursed as well. William Osler said that 90% of the diagnosis is with the history and physical, but because of our healthcare system, the amount of time spent with doctors is dropping. So what is it in primary care? 8 minutes now. Specialist is about 30 minutes. There's another part to this that I think we should point out, and that is the assumption, and this gets back to the dualistic model, is the assumption that if they don't find anything, then it must be psychiatric. And here's a great cartoon. You can tell where that's from, I'm sure, the New Yorker. And you've got this, it says, well, the old body checks out. Let's see what Doc Atkins here makes of the old mind. And if you're an aficionado of nonverbal communication, this doctor looks very happy as he literally washes his hand in the case and hands it over to the psychiatrist. And the patient, if you look at her eyes, there's surprise, and her lips, there's non-acceptance. And why shouldn't there be? Because no one made a diagnosis of a psychiatric problem. It was assumption based on the lack of organic disease rather than something positive to say there's a psychiatric problem. And this is what can happen. And it gets worse because we then develop attitudes toward the patients. This is a grid that, This is a grid that shows a disease relative to illness. Now, the absence of disease and illness, and again, we're defining disease as objective, verifiable, observable abnormalities, and illness, the perception of ill health symptoms. The absence of both is health. If you have something like chronic lung disease or cancer or AIDS, it's called rightful suffering because they're concordant along this line. But what about if you have illness without concurrent disease, such as chronic fatigue, abdominal pain? It's called functional, but it also is considered psychosomatic, which is to some degree a pejorative term, meaning that it's made up or in the mind. Here's a study we did a few years ago with gastroenterology fellows, where we had them rate after, and the stressor here was nighttime calls. So they were on call at night, and they received calls from patients or on the weekend, and they had to rate the patients in terms of the seriousness of the problem, how disabled they thought the patient was, did they think the patient's request was reasonable, did they feel they were helpful, were they satisfied with their recommendation, did they like the patient? And what you can see if you break it down to those who had functional versus organic meaning Crohn's disease, peptic ulcer disease, esophageal reflux, functional being irritable bowel, dyspepsia, you can see that the attribution of it being meaningful was lowered for those who had a functional GI disorder, even though the complaints were the same. Complaints of nausea, vomiting, of diarrhea, of abdominal pain. But the doctors treated, or their attribution about the importance of the problem was reduced when it was functional. And we see it in the cartoons, our negative attitudes. And psychiatrists are also, they're supposed to be listening and thinking, but they have the same difficulties. This is single session therapy under managed care. Now, Paul Valéry was a artist and a poet who made this statement: to see is to forget the name of the thing one sees. I think what he was talking about is to experience something in its purest form. You don't want to be biased by predetermined concepts or ideas. And isn't that what we're seeing here with the patient with functional GI disorders? When the GI resident or the fellow or the student says, I have someone coming in with a functional GI disorder, they prejudge the patient before they get to know him as an individual. So we get into this vicious cycle. The patient comes to the doctor. They have urgent requests. They make visits and urgent requests to do something. They're looking for something structural to be found. They request tests. They expect cure. The doctor might order tests, put them on drugs or surgery. There might be iatrogenic harm. Finding nothing, they tell the patient there's nothing wrong. The patient gets frustrated. They get frustrated. They become hypervigilant in the sense that what they're doing is focusing a great deal on their symptoms, wondering should they go to another doctor, and they develop symptom-related anxiety. Maybe something's being missed. And how do we get out of this solution? And I think that the solution is not to keep doing tests, but to abandon the effort to do so. Take a step back. Accept the reality of the patient's condition as real, even though a specific diagnosis hasn't been found, and then you work with the patient towards solutions or goals by listening, by understanding, and that's where we get to the idea of communication skills, by providing effective communication skills. Now, here's a study that is very interesting that we did with Ted Kapchick in Boston, who's done some work with placebo. And what we're looking at here are patients with irritable bowel who were treated with acupuncture, sham acupuncture, and there were three conditions: a wait list, patients who were told they'd come into the study but didn't come into the study, and that's your control group, and then limited and augmented sham acupuncture. The needles were placed in the same place, but one got what's called augmented acupuncture and the other limited. And you're seeing improvement in symptoms and improvement in quality of life. And what you can see is that the limited acupuncture was no different than the wait list, but the real difference was in augmented acupuncture. What do you think augmented acupuncture was? Yeah. These people, the acupuncturist was trained how to communicate and listen empathically, whereas the acupuncturist in limited was just doing the technique and was trained not to respond.
None of it was actually acupuncture.
It was sham acupuncture, right. It's another study to do it with real acupuncture. We haven't did that, but the point is it's showing you the difference. Even if it doesn't work, you're seeing the difference. So let me talk a little bit about, we'll move on now, to what are good communication skills. And what I have to say here, it doesn't have to be doctor-patient. If you've been a lawyer, if you've been a business person, it's really communicating with other people. What are the things that make a difference? And the first thing is satisfaction. Now, in the healthcare system now, satisfaction is huge. It's the way these ACOs and these new accountable organizations are going to define success, patient satisfaction, and you may be going to doctors and their offices are sending you satisfaction surveys in order to get proper feedback. What is it that patients want in order to be satisfied? Some research has been done, and there are 4 things. One is the doctor has to be seen as humane. The second is they have to be seen as technically competent. The third is they have to have interest in psychosocial, your life story, your family, and your psychologic milieu. And the fourth is they have to provide provision of medication often based on what your interests and needs are, as well as about the condition. If there's too much interest in biological material, it's actually a negative factor if the doctor talks too much about tests and things like that. The second point that's very important is the idea of engagement. Engagement means that the two are, that the patient is seeing the physician as part of the mutual goal. They're working together. And what the measures are for engagement is actually seen here. Good eye contact, affirmative nods and gestures, a gentle tone of voice, close interpersonal distance, and the development of a partner-like relationship. This leads to engagement with patients. Think about the doctors you've seen. What score would you give them for being able to develop engagement with you? A third point has to do with the doctor's satisfaction, and it's been shown that doctors who learn good communication skills are more likely to like their job and to like their patients. And the patients are more likely to reciprocate and like their doctors. What are some of the techniques? We'll go through a few of these techniques, which I mentioned you can do this any place when you're interacting with people. The first is active listening. We tell this to doctors, say, oh, I always listen actively. But it's not cocktail communication. Now, cocktail communication is you're at a cocktail reception, you're holding a drink, the other person's holding a drink, you're talking about your children, they're talking about their children, you're going back and forth. If you stopped it at some point and asked one what the other one was saying, he might not remember because you're so concerned about waiting for that gap to get in and say what you want. Active listening is hearing what the other person has to say and using that as a basis of defining what you're going to do next in terms of what you're going to say and what you're going to do. Identifying the agenda. Patients and doctors always have agendas. Sometimes these agendas are articulated immediately. Interestingly, sometimes these agendas only come out at the very end because it's a little scary to talk about. They're called doorknob questions. And sometimes they don't really come out at all, but the patient is dissatisfied that it wasn't discussed. These are the kind of things that patients worry about. I suggest to the doctors that there is 4 very important questions they should be asking. What brought you here today? Well, that's pretty obvious if you sprained your ankle. But if you have chronic pain for many years, why are they coming now? There's the emergency room doctor who sees a patient come with back pain and they say at 3 a.m. on a Saturday night and said, how long have you had this? And they say 3 months. And then, why are you coming now? You need to understand there might be other issues. There could be disruption in the family. There could be compensation issues. There could be that the pain is just more severe. What do you think you have? Okay, I think that I have an infection, and I've been to 10 doctors over the last 2 years, and all the tests have been negative, and I'm sure I have something hidden. Well, that may not be realistic, but it does open the door by understanding what they think they have to reframe their understanding, what's called their schema, into a way that makes sense, that would be helpful. And we'll get into that in a minute. What worries or concerns do you have? What do you think the biggest concern is when a patient goes to a primary care doctor with pain? Cancer, right. What's really interesting about that is that it's not uncommon for the patient to come in, not raise that concern. The doctor does an evaluation. He or she does some tests and says your pain seems to be fine. We don't have a great answer for it, but you're in good health, everything's fine. And what does the patient go out thinking? What do I have? Do I have cancer? Because it wasn't articulated. So if the doctor says, what worries or concerns you have, and the patient brings it up, there can be a dialogue around that. And then the doctor really understands that that was the patient concern when he or she didn't know that before, and they can work toward addressing that particular question. And then finally, what do you feel I can do to help? This is an important one because I've had some patients come to me, sit on the table and say, I'm not going to leave till you open me up and find out what's wrong. And that's not a realistic request. But this has to do with sometimes the gap between what the patient's expectation is and what the doctor's understanding is of the problem, that they haven't really communicated this effectively. And I'll show you that in a minute. Empathize. Empathize is understanding the person's distress, but maintaining an objective, observant stance. That's very different from sympathy, where you, like a family member, where you're sharing the experience. You have to have a little bit of distance in order to make appropriate judgments as a clinician. I can see how difficult it has been to manage with your pain as an empathic statement. And as you see these, think about yourself as a patient going to a doctor who asks about all your symptoms and does or doesn't say this. Do you have a different sense about this person? Validation is close to that. It's creating a bridge between the patient and the doctor. I can see you are frustrated when people say this is due to stress and you know it's real. Now there's a gap here between what the doctor really wants to communicate and what the patient's feeling. The doctor feels that stress may be playing a role, but the patient is interpreting that as not being real. And so the doctor will have the opportunity, when providing this validation, the patient will be more accepting of looking at other possibilities. Let's try this video.
You've given me a pretty good idea about the nature of the pain. I guess I want to understand a little bit more about what makes it worse. Are you aware of anything like diet, activity, or stress?
You don't think this is in my head, do you?
I guess I need to understand better why you're asking me that.
Well, several physicians have suggested that stress is what's causing my pain. And Dr. Smith, my primary care doc, have sent me even to a psychiatrist. And the psychiatrist thought I'm fine. And I know I'm not crazy. It's not in my head, and I did not have this pain before, and this is very frustrating.
So I guess you're concerned that other doctors are saying that this is stress, and you're wondering by my question whether I think that this is a psychiatric problem?
How would you feel?
Well, you know, as a result of our evaluation today, I know that your GI symptoms are very real. And this is not a psychiatric condition, this is a GI condition. But
Thank you.
But just like any other condition, I think we need to understand what factors make it worse. And there can be things like physical activity or stress. And one of our jobs is going to be to try to see which kinds of things might make it worse. And then by having that information, we can work out some solutions.
So you don't think it's in my head?
No, I don't think it's a psychiatric problem at all.
Okay.
This is Dr. Albena Halpert, who's a gastroenterologist in the Boston area, and she's a very good actress and tries to make it very difficult for me. She'll never feel satisfied with what I try to do. Let's look at what we did. The issue of either or, you don't think it's in my head, do you, is a common complaint question, and it really is a problem if you say yes or no. If you say yes, it's in your head, that's not going to go over very well. If you say no, it's not in your head, that's not the reality, that stress can affect all illnesses, lower pain thresholds and the like. So what I was trying to do was to get past the point of this challenge as to what my view was on it and get to a kind of a, like under the iceberg, a clearer reality. So I asked, why is the patient asking? And she came back with that, well, Dr. Jones said it was psychiatric. And so I reflected back and said, so you're wondering by my question if you think it's a psychiatric problem. So I was separating out a psychiatric problem, which it was not, from the idea of stress. And so I distinguished the stigmatizing term psychiatric from stress. Then I validated the feeling that it's not a psychiatric problem while maintaining the plausibility of stress as a factor. So that's a way to kind of open the door for further discussion. And that goes wherever we see the patient wants to go. Setting realistic goals. We want to set up an initial mutual understanding of this. And this is where we have the patient who comes in expecting cure, and you know that this has been going on for 30 years. And when you have a condition that's going on for 30 years, it's very difficult to expect that there's going to be cure, and you have to reframe expectations with the patient. I often will use the term, it's like having arthritis. You can't cure, you can't make it go away, but you can get it more manageable and get it under control. If you share the experience of the outcome, it's going to be a lot easier to work on it.
Well, how are you doing today?
Hi. Same old. No improvement.
Hmm.
You know, I was thinking in the waiting room, I've been coming here for 3 months. My pain is still the same. I know you're trying hard. But there must be something that should get this pain better. I've taken 3 Darvocets before I came here. That's why I'm so comfortable now. The pain is really, really bad. Is there something you can do?
Well, I guess maybe we should, I would like to get a better sense of what your expectations were at this point about how you would be doing.
Well, I was just hoping I don't have to take Darvocets all the time, and that my pain will be better.
Yeah.
That's all.
What would be better?
Well, gone will be good.
Yeah.
I want it gone.
Yeah. And you've had this for how long now, this pain?
Years.
Yeah. Well, I'm just wondering that...
I'm tired.
Yeah. I'm just wondering that maybe we didn't really talk about expectations on the first visit, and you're coming to me now expecting that the symptoms would be gone, but I guess I've seen this as a very different kind of management. You know, you've had pain for many, many years, and I think we have to be realistic in terms of what our expectations are.
You mean I have to live with this?
Well, you do have a chronic condition, much like arthritis, and you know, the disorder doesn't go away, but it goes up and down in terms of its intensity and severity, and what we work on are ways to manage and keep the symptoms under better control.
You mean I'll have to live with this? It's starting again now. I have to live with this forever?
Well, it sounds like that after all these years of pain, your expectation was that it would go away completely, and I think that while we hope that would be the case, is not fully realistic. I think we have to look at ways to reduce the symptoms and make you feel more able to control them.
I cannot function with this pain. I have to get better. I cannot work. I cannot take care of my daughter. My marriage is falling apart. You've got to help me. I just cannot live with this.
Well, you know, you've raised many different types of concerns and issues that we may need to understand and address better. And I think with regard to the pain, realistically, it may not go away, but I'm just wondering if we were to get your symptoms down about 25 or 35%, if that would be beneficial to you.
Well, it would. I don't know whether I can work still, but I'll take it.
Now, to some people, this might look a little uncomfortable. You kind of want to provide that support. And we have an agenda here where we want to try to get an effective relationship going. And so the way this was approached was to provide some reality to it and to offer to work with the patient. But you can't promise you're going to make it get better immediately. These are the patients who are vulnerable to getting narcotics. And they overuse the narcotics, and we get into additional problems. So I avoided responding defensively to the challenge. Isn't there something you can do? When a doctor hears that, the response could either be to jump in and do something like prescribe something when they're not addressing the chronic illness nature of this, or they back off and they get frustrated. So I maintained a a neutral point, and I asked about patient expectations. Now, as it turned out, I saw the patient 3 months ago. We never addressed what her expectations were. So now 3 months later, she's coming in frustrated because I didn't make her better. But if we discussed the expectations back then, I would have said, as I said today, this is a chronic condition. We have to work on getting reasonable gains over a period of time with chronic pain. And we would have obviated this exchange by dealing with it the first time. Have to live with this forever. These are statements that are very difficult to, and I think this is where I say don't just do something, stand there. Maintain a position of offering to work, showing your agreement, willingness to work, but we need to have realistic goals for the future. Education is not giving someone a brochure. It's an iterative process. You want to first elicit the patient's understanding. You address any misunderstandings that might occur from the patient's schema, and you provide information consistent with the patient's frame of reference. And then you check on the patient's understanding of what was discussed. All too often you're left with a video or a brochure, and there's no opportunity to ask the questions that seal the information better when you have a dialogue. Reassurance is not a pat on the back. Reassurance is identifying their worries and concerns. What are your concerns? Acknowledging them. I can see how these fear of cancer could be a real problem for you. You've lived with that worry for so long. You respond to the specific concerns. Fortunately, we have done a large number of tests to identify possibilities for cancer. Your colonoscopy is negative, the CT scan is negative. But we have to keep an eye out. If anything changes, I want you to get back to me in the future, blood in the stool or things like that. So you're kind of sealing a contract that at this moment, nothing more needs to be done. There is no evidence for cancer. 5 years from now, if something comes up, we'll be looking for it. The last thing is negotiation. And the next to last thing is negotiation. And you know, we're talking these days about patient-centered care, the idea of letting the patient play a major role. I would call this relationship-centered care, because what you're doing is you're working as partners to, the doctor provides the information, and then the patient gains a level of control through helping make decisions. I have medicine A, which has this effect and this side effect, medicine B, this effect, this side effect, medicine C. Which do you think would be preferred? Well, you're the doctor, and I'll say, well, I might lean toward this, but it's really your choice. And you kind of get in that dialogue. As long as you're not giving all the responsibility away, you're making the judgment with the patient. And then finally, as I mentioned, sometimes patients' agendas or ideas come up at the end of the visit, and sometimes they get set off because the level of communication and trusting is going so well that up comes some very strong feelings relating to earlier events or difficulties, and you have to be prepared to hear it, to listen to it, to be non-judgmental, and to provide support. Patients want to be understood. They don't want to be abandoned. They want a sense of hope. And in these situations, they want to be heard and not feel shameful for having brought it up. Now, the next video gives an example that I actually use in training a higher level of communication skill, where we're working with a patient who has a history coming up of abuse. And in this situation, I'm trying to stay with the patient, but also offer the opportunity to get further help, but the patient is highly ambivalent about it. So you'll see what happens.
You know, you've told me about your symptoms, and you brought up on several times about how you felt very helpless and out of control and vulnerable with these symptoms. I'm just wondering if there are other times in your life where you've had similar types of experiences.
Well, Is that important?
Well, I was trying to understand the feelings that these symptoms have generated.
Well, my childhood wasn't, always pleasant. My father was an alcoholic. He wasn't very nice when he was drunk. But I don't see how this has anything to do with my pain.
Well, I guess you're bringing that up now. Were there certain feelings that were generated or experiences that brought on those feelings?
Yeah, I actually don't particularly like talking about it. But probably age 5 to age 15 when my mom left, was pretty rough.
I see.
He was not a good man. I really don't want to talk about it though.
Yeah. Well, I guess I was just looking to understand if there was any relation between the symptoms and the feelings generated now and the feelings generated then. It sounds to me that there may have been some feelings that made you feel out of control and helpless then too, and maybe that's having a role in the symptoms now.
Oh, I was totally out of control.
Yeah.
I was scared. I was hiding when he would come home because I knew what was going to happen.
Yeah.
But he's gone now,
Yeah.
and I have this pain.
Right. Well, what struck me is that in describing the pain, you use the very same words, and there's no question in my mind that those very difficult experiences can be almost indelible in your mind. And
You think?
well, they're issues that you have to work through, and I'm just wondering if you're having those feelings now with your symptoms, that in some ways it's kind of bringing you back to that feeling of helplessness and lack of control. And that's something we can work on now. We can't change the past, but we can maybe work on these symptoms now in a way that you're not responding as if you were a little girl.
Okay. I think I'm still a little girl.
Well, what we need to do is to have you work with these symptoms in a way that puts you right back in control. And I just have a feeling that in doing that, these symptoms will be much more manageable.
But is that possible? Can you turn the clock back?
Can I turn the clock back? Well, I think that's something we can decide. Obviously, this is something that you find very difficult to talk about. And if you are interested in addressing this further, perhaps we can talk about it, or might have you see one of my colleagues who can work with you on that.
I don't know.
Yeah.
I haven't talked about it to anybody.
So it's really been preying on your mind some?
It's been better. It did for a long time.
Yeah.
This is really hard. Anyway, what are we going to do now?
Well, I think now's the time where we can work together to get you feeling more in control of your symptoms and maybe find better ways to manage your symptoms. I'd also like to be available to you if you want to discuss those past experiences and see if we can make some decisions about what to do about that.
Thank you.
You could see the struggle that was going on, whether to discuss it, to feel trusting. Our research group back in the 90s had an NIH grant to look at the role of abuse in gastrointestinal illness. And this is not a very different scenario, in that one of the things we learned was that abuse doesn't cause these conditions, but abuse amplifies the experience to make it more threatening. So if you've had early life traumatic experiences, physical or sexual abuse, it will affect later in life sense of ability to handle new challenges. They become more threatening. Working with doctors they may feel more vulnerable. And so it's the emotions around the experience that carry through. So when a patient says they feel helpless, out of control, and shameful about their symptoms, that could be a trigger that they could have had earlier experiences that are being played out later. So what I did here was I was non-judgmental, and I can also tell you that this kind of scenario, these are all role plays, but if I had a patient like that, it's more likely than not that at a future time, she would want to talk about this further, but she just had to process it. So I was non-judgmental. I used questions and reflections. I addressed the patient's feelings of helpless and out of control as related to the symptoms. How do these symptoms make you feel? I reflected on the similarity of the current feelings to feelings generated from earlier traumatic events. And I used silence and reflection as a means of support. And then I acknowledged options for further exploration. But in the end, the choice was her. If I were to press her into doing something, that in itself could be considered abusive. So I wanted to let her make the decision and offered availability to discuss further. Now, the last thing I want to do is a little bit of an exercise for you. I think you heard that I'm on the Institute of Medicine committee, which is working with the Gulf War, the Afghan, Iraq, Enduring Freedom vets who come back. And as you know, they're coming back with a whole host of problems, PTSD, and we're working on a committee looking at chronic multi-symptom illness. So they'll come back and they'll get 5 or 6 different kinds of symptoms. And this would be in the category of functional because the workup is negative. You don't see anything. And we have some ideas about what's going on in terms of brain-body signaling and interaction, and there's some brain imaging studies to support this. So the definition is a spectrum of chronic multi-symptom illness present for 6 months or longer. It includes complex chronic symptoms, as shown here, that may overlap but are not fully captured by existing syndromes, IBS, chronic fatigue, and fibromyalgia. So it's not one of those distinct syndromes, but it's a collection of symptoms. Now, the challenge is that the veterans are not feeling adequately cared for. The VA system is trying to find more effective ways to treat them. And one of the things that we came up with is the value of the communication, the VA doctors learning how to communicate effectively. Because we're dealing with no precise diagnostic test or treatment. We found there's a discrepancy between the beliefs of patients and their peers, particularly what they see on the internet, compared to their providers on the possible causes and treatments. There's a fear of this being seen as psychiatric. The providers may focus on diagnostic testing, much as we talked about, to exclude other diagnoses rather than accepting this condition as valid. And the treatment involves not only the symptoms, but there's a tremendous impact on the spouse, quality of life, emotional state, and their functioning capability. So what I want to show you now is a good and bad dialogue. I'm going to play the bad dialogue, and I want you to see if you can see where the bad parts are based on what we've gone through, and then we'll show you the other.
Hello, how can I help you? I got another flare-up when I came back from vacation. Fatigue, muscle ache, stomach pain, and terrible nausea.
Was this like you had before?
Well, almost, I think.
Was it made worse by food?
Yeah, I think so.
Did you have a fever or chest pain?
Well, yeah, I think, but I didn't take my temperature.
So you had a fever and chest pain?
No. Well, the pain wasn't so bad, I guess. Doctor, I'm really worried about this.
All right, let me schedule you for some blood work and maybe another x-ray. It'll probably be okay, but we'll be sure at least that nothing is there to worry about.
But what do I have? I saw on the veterans' website some other people had the same things, and they called it Gulf War syndrome. Is that what I have?
Well, most people aren't sure whether that's a real medical condition, so I want to rule out anything else that we can treat. If the studies are negative, I'd like to put you on an antidepressant to make you feel more comfortable.
I'm not depressed. I just can't deal with the pain and nausea.
I didn't say you were depressed. It can help the symptoms. Let's just see what the tests show.
Any problems? Not hearing? It's typical. What's the typical part? What's the typical part? What are you hearing?
The responses that the provider is making.
No eye contact, multitasking rather than concentrating on the patient.
Yeah, typing.
Suggesting what the illness is, feeding a possible response from the patient, suggesting to the patient other entities of illness.
And this is what we hear the veterans complaining about, so we're trying to help change that. Yes?
There's sort of this God and not God thing too. You get the feeling that the physician feels that he is way above the patient, and the patient kind of realizes that.
Well, being cut into is one example of a hierarchy here, too. Anything else? Yeah.
I think the doctor shouldn't have used the word antidepressant. He might have been much more productive to use the word medication that might make you feel better.
Okay. We're going to come back to that with the next one. I could answer now, but I want to see what they say next. Yes?
Stating that he isn't sure whether his symptoms are a real medical condition.
Right. He's invalidating the reality of it. Yes?
Looking at the watch.
Nonverbal behaviors are very major.
Body language too.
And interrupting the patient continually.
Okay.
Suggesting a chemical solution that early is, what's different from that in a drug pusher on the street?
All right.
I mean, it's being pushed every place. Television.
All right.
An easy fix.
An easy fix, right.
After the baby has a fever, may I have an antibiotic?
You got the sense the doctor wanted this to end, too, All right, so here we are. The doctor made this has all been discussed, little or no eye contact, was reviewing the chart or typing. The doctor's question did not effectively gather information. We used closed-ended, direct, multiple choice questions, interruptions, little opportunity for the patient to tell the story. The dialogue was even confusing. At one point, they were speaking from different agendas, like the cocktail party stuff. The doctor dismissed the patient's concern about the diagnosis of Gulf War syndrome. We don't know if it's real. He closed discussion by looking at the watch and offering to do tests, and offered an antidepressant if the studies were negative, but gave no reason. And the patient assumed the medicine was for depression, which he did not think he had. Okay, let's look at this in a different way. Same number of iterations.
How can I help you?
I got another flare-up when I came back from vacation. Fatigue, muscle aches, stomach pain, and terrible nausea.
Yes.
I was about to start my new job as floor supervisor, and then all this happened.
Oh, I see.
I started getting those muscle aches and fatigue, and then the cramps came right here. And it got worse after eating. It felt like a stomach flu. I felt warm, so I knew it was getting worse again, so I came in to see you. I'm really getting worried about this.
How so?
Well, it's cutting into things. Can't do sports, can't go out to eat, and I'm worried about my job. I'm irritable and not doing a good job at home, but my wife is really terrific. And then, I got this promotion. What am I going to do if I can't do the job because of this?
I can see how this is really affecting your life.
That's right. Sometimes I don't think anyone understands. Doctor, what do I have? I read this veteran's website, and people there have the same problems. They're calling it Gulf War syndrome.
Yes, it's hard when it seems that no one really understands what you're going through. There is a lot of discussion about Gulf War syndrome, or what we now call chronic multi-symptom illness, or CMI. You are not alone with this, and the VA medical system is working to understand the causes and find treatments. I see from your records that you had full medical evaluation a couple of times, and based on your symptoms, you have CMI. So I'd really like for us to focus on ways to manage your symptoms.
Sounds good. So what do you want to do?
Well, first off, I want us to work together on this. There is no magic pill. I have some ideas that may help you get back to the life you want. I can see that these symptoms are so bad that they also affect your emotional well-being, your family relationships, and your quality of life. So while we are working on getting some relief for the symptoms, I want you to also see a colleague of mine, a psychologist, who will work with you to develop coping strategies and help you find ways to get back to a more normal lifestyle. I also would like to put you on a certain type of antidepressant that can help reduce the pain and discomfort you are experiencing. They act on nerve pathways from the brain to your body to help block pain signals, and they often can be used in lower dosages than for treating depression.
So it's not because I'm depressed?
Well, medicines have different effects. Aspirin can relieve pain, but it can also prevent a heart attack. Certain antidepressants are also used to treat a variety of painful conditions like body pain, irritable bowel, and even pain from diabetes. Of course, if a CMI is making you feel depressed, then it can help for that as well.
Okay, that sounds great. I'll give it a try. Thanks so much for your help, Doctor.
Any difference? What do you pick up here? What are we've actually covered all of this. What was done here? How can you articulate some of those things that went on?
Validation.
There was a validation. This is affecting your life.
Listening.
Active listening.
Lots of agreement.
That's right.
And actually, the doctor was talking a lot more in this than in the first session. But the doctor was relating to the patient rather than talking over the patient.
Right, and it was, there were more words. The iterations were the same, but the words were reflecting what the patient was asking, as opposed to being a different agenda.
There was empathy.
There was empathy communicated.
There was also a certain amount of education about how medications function in more than one way.
Right, especially with the antidepressants, because, you know, we call them now centrally acting agents or neuromodulators.
That also assumes that the physician is now crediting the patient with a certain amount of intelligence and becomes a co-owner of the situation.
Right. Providing a team approach, that's one of the issues, is working in teams for some of these, having a psychologist available too to work together. Yes?
You certainly do have to allow the physician more time, though, for this kind of thing to go on than the 8 minutes or whatever it is that you currently get. How the insurance company is going to.
Well, I think the insurance companies are going to have to, we're going to have to find ways that they reimburse, because there will be better evidence that this will lead to better outcomes than just ordering tests. Yeah.
My impression wasn't that the second version took any longer than the first one. I think if you clocked it, they'd be very similar.
They are. They're about 15 seconds different.
Yeah,
Yeah.
there's just far more to the point, the second one.
Yeah, the active listening leads you a much more focused, as opposed to a lot of noise that goes on when you're, you know, talking two different ways. Yeah.
It seems that in order to perform this way, the normal doctor who's treated to be a clinician in the sense of a mechanic has to be trained to be more of a psychologist, and sometimes that's been some conflicts. I knew a woman, Cheryl Elhern, who at Harvard Health was trying to get the doctors to do sort of the same thing.
Well, I think I trained with someone named George Engel, who said that the effort was toward the medical physician providing this role of dealing with the psychological issues were very much a part of the medical illness, but it wasn't solving psychological problems as much as understanding in the context of the illness the psychological effects and working in that way. But I think if every medical doctor learned this, they do learn this, supposed to learn this in medical school, there might be a very different type of care going on. I think what we should do now, I think, is I think this is the end of this talk, but now we'll be moving more toward, maybe we'll talk a little bit about some questions and answers. Oh, I did have one more slide. I think I want to, the number of iterations are the same, but the content and communication more effectively engages the patients and optimizes the relationship. The doctor's statements were facilitative, active listening, gave the patient an opportunity to say more. He actually volunteered by the silence how it's affecting his life, the stress of the job, the promotion. Validating statements you heard, I can see how much this is really affecting your life. You're not alone in this. These are very powerful validating statements. Offered to work collaboratively, as I mentioned, patients want to be understood, given hope and not abandoned, and recommendations for the psychologists and the medications. Okay, thank you. Can we take questions? Yes.